The capacity to promote health never lies exclusively within any one individual, organisation or profession. And the richer our vision of health and the broader it becomes in terms of health and well-being, the more true that becomes. And so richer goals require a broader range of contribution. And therefore, if you're Jeremy Hunt with a responsibility for the NHS, actually the only thing he can do to make a difference is to influence the ways in which different individuals or professions or organisations come together to create value or to produce social goods. That is the only kind of tool that you have as a manager of organisation, as a politician. So to think about how is it that you influence those relationships, and perhaps from a commons point of view, to actually then model what are those relationships quite specifically, so you can say, actually, in very concrete terms, this is what it looks like. And therefore this is the change from the current reality of relationships to a new set of relationships, and that's the route map of which relationships need to change and in what ways. I think secondly then, a lesson from the past, going back to the formation of primary care groups, a lot of health professionals were very excited by the opportunity that was going to create to form new collaborative relationships to generate a public health-led NHS. But working with City University, we ran a number of simulations for leading-edge GPs and primary care organisations. And in those simulations, every single group folded because they were so excited by all the new external relationships that they could form that actually the internal relationships within the group fell apart. Because the reality was when we talked to GPs, life had been fairly simple, 4 key strategic relationships, your health authority, your hospital, and 1 or 2 others. We then talked to them and said, well, actually, they were identifying 15, 20 key strategic relationships. And it says, where does the time come to invest in all those new relationships? If you were putting on someone, you've got to create 10, 15 new relationships, which are going to be the future of the commons. And you're already feeling stressed and overworked. Where does the time come? How do you start to make that transition? Or from the point of view of the public, if you're a tired, stressed, overworked young mother, you may like the idea, in a sense, of a creative commons, but actually you're exhausted and you just want it delivered to you. So in terms of engaging with the public, who actually may be quite comfortable with having health delivered to them, how do you create, in a sense, that capacity, that energy, that belief that you actually can be involved, and it will be, as Lisa was it, that can be a life-transforming difference, rather than actually laying on a different burden. Think, for example, of voting for crime commissioners or police commissioners. It's just another thing to go out and do. It doesn't kind of energise and grab people with a vision of, yes, this is our opportunity to make a difference. So how does the public engage? I think there's a challenge for professions. I ran a project looking at countries undergoing comparable experiences in modernisation, and say, well, what does that mean in terms of stewardship of health resources or driving forward quality? And the outcome of that was for professions recognising that they had 7 key relationships with individual patients or service users, with the community, with their own profession, with other professions, with new partner organisations, and with various policy bodies. And to actually say, well, to be a profession is no longer simply a knowledge-based sort of territorial defensiveness, but actually to say it's professionalism in the conduct of all those key relationships. And actually, how do you help new doctors going into training, new health professionals, to recognise that actually it is those relationships which will be the key to their performance, the key to avoiding service failures, Victoria Clambier, Bristol Heart Desk, all those around failures in relationships. So how do you help young health professionals to recognise that these relationships are actually, again, expansive possibility for future performance? Perhaps the answer lies, and I think you've already indicated, that actually it becomes easiest with the most vulnerable groups. And therefore we might think about, as a starting place, disability groups, user-led organisations for disability, that actually where people have felt least well served, where there is, in a sense, some group identity and a collective desire to make a difference and to transform those lives, it is in the most acute recognition of failure that the possibilities seem greatest. Now, the difficulty with user-led organisations is that actually they haven't got, in a sense, that co-governance status. And in a sense, we need to look at the way the money flows within the system. That too often local authorities hold on to the budgets, they're not really delegating significant slices of money, not willing to let go of the control. And how do new emerging groups actually create their own independent democratic legitimacy? What is their, in a sense, their accountability? Because I think we will always remain hampered by that sense, which is in one sense very positive, that a doctor, a GP, will continue to regard themselves as the custodian of health. I mean, that is, in a sense, the Hippocratic Oath, that's their responsibility. And actually, it's quite a big step to let go of that sense of a professional responsibility for somebody else's health to a more co-creative relationship. And how, in local politics, in local democracy, how do we let local authorities let go of responsibility and control to new community groups and to organisations to deliver, create new services, even if that means making their own staff redundant? And that's always a big stretch for a local authority to say, actually, we're not going to be the brokers of services, we're going to let this charity be a service broker. Too often it doesn't happen. So I think there are many changes and challenges. I mean, what can look great in theory will rub up against all sorts of quite practical difficulties around time, and money, and energy, and enthusiasm, and control, and safety, and safeguarding. So it's making it, in a sense, safe, realistic, challenging, and possible, and maximising the potential for saying, yes, this is the way forward around the difficulties that you're failing to overcome. And that's why I think actually it looks best around mental health, disability, because that's where the failures are currently so much more acute.
Thank you very much, John.